I have to make the case a little bit for early surgery, and I'll give you some of my thoughts. And I think you saw from the last talk a little, the data here is a bit soft, but I'm going to give you the my perspective on it with some data. It's interesting, I have to debate my esteemed colleague, Dr. Jim Harrop, who actually supports this point of view. So in the data.
By the way, that's totally not true.
Yeah. If you believe what he writes, if we can believe everything that Jim writes, he's a prolific writer.
In 2002, when I wrote that paper, that's unlike John, I actually evolved my book.
So I think it's important first we define what we're talking about here. Okay, so we're talking about low energy injury to the cord. Usually falls from standing, typically in extension. They often have a bruise on their head. Mostly older people, some young people that have pre-existing congenital stenosis. These are all incomplete spinal cord injuries by definition to be a central cord, usually upper extremities greater than lower. It can be severe as an ASIA B. Okay, those are not common. It can be as mild as hand dysesthesia, paresthesias. And the residents will often call me, the ER's called him, worried about something. All the patient has is dysesthesias in the hands. They don't want you to touch their hands. I say, that's a central cord syndrome. That patient dinged their cord even if they have no motor deficit. So it can be that mild. There's no demonstrable fracture or ligamentous injury on CT or MRI. And if these exist, it goes into the category of fracture, injury, dislocation. It's a different beast at that point. Okay, so there's usually underlying degenerative changes that's already compromising the cord prior to this. There's no new compromise, an inciting event. So what's happened is as it's extended, they've essentially punched their cord. I think it's almost like a concussion of the cord. So there's no new canal compromising lesions. Okay, so redefining it, people have been talking about, this is a nice little article sort of rethinking this concept that this is really an acute traumatic myelopathy. Okay, that's a nice way to think about it. And this article kind of outlines that point of view sort of nicely. So years ago, you heard there was concerns about the negative impact on the cord by early surgery. This is because of the surgery they did, the techniques they had. This has long been debunked. So early surgery does not create injury unless you cause an injury during the surgery. Okay, so once someone presents with a central cord from a minor injury, they've now demonstrated that they're at future risk. So it's very rare to see this in someone who has a normal open canal. Occasionally, like a neuropraxia from a high collision injury in a football athlete. But generally, they've now shown you they're at risk for this problem. And that risk will not go away even if they get better. So knowing that, their underlying pathology probably should be addressed surgically at some point in time. That means surgery, unless they have prohibitive medical contraindications, maybe a really mild with very minimal compromise. But as a general rule, they put themselves into a category that we at least have to give strong consideration to doing surgery. When I have an injured cord, injured cords like to be like no motion. Like the cord does not want to continue to move. Every time we flex and extend, we compromise our canal. So I put central cords in a collar if I was going to treat them non-operatively or watch them recover. So they're going to go in a collar for 6 weeks for me. That's what I do. Logistically, they're in the hospital. They're likely to be there for a few days at least. If we're going to use MAP pushes in our facility, those go on for 5 days. There's some places use 7 days. So they're going to be in the hospital for several days. So what's the downside to early surgery? They might as well recover from the surgery as they recover from the spinal cord injury rather than make them two separate events. We'll let you recover, we'll bring you back in 2 months, put you in a hospital again, and keep you there. Maybe put you in a collar if the surgery warrants it. So it logistically just makes sense to do it early. So how early is early? What do we mean by this early surgery? So there's two goals. One is to enhance and improve recovery. And you'll see the data for that. There is some data to suggest that that's worthwhile. The other is to protect from future injury. And there are no known studies, unless Jim knows of some, to determine the risk of a central cord syndrome and how severe if you get a second central cord. I know of no case series of that. That's would be an interesting concept. So there's data that says surgery is better than non-operative treatment. There are several papers that have seemed to indicate that. In this review in 2013, there were 6 papers on timing that were unable to really show an effect from early surgery. But the problem is those papers varied from 2 weeks as early surgery to 24 hours. Even the 2-week study, though it's interesting, showed some improvement. That's one of the papers that showed more improvement. They're all retrospective, okay? They did define some poor prognostic factors, which were how severe it was in the first place, and age. And you'll see severity of the injury may play a role. This is all class 3 evidence. So this is a study that looked at delayed surgical intervention and similar conclusions. They couldn't define a benefit from early surgery. So, but it was insufficient to make any kind of strong recommendation. The data is soft. Interesting, there's Harrop. I think early versus late. This study is one of the studies that really supports early. Dr. Jim Harrop. 22, Jim. That's only a year ago.
I know my mind moves a lot faster than that. I'm going to show you how bad.
So this was they did a propensity score match cohort study of 3 different multi-center databases, and they used 24 hours as early or late. There were 93 patients in each group. And the data is soft, but it did seem to indicate that early decompression significantly improved motor recovery in the upper limbs, not so much effect in the lower limbs. It may be because the lower limbs were less involved and got better quicker, but maybe a little bit in the upper limbs. The outcomes were comparable in the mild injuries, the ASIA Ds, but were more pronounced in the more severe injuries such as the ASIA Cs. You may want to put that in your thing, Jim.
Don't worry about it, John. I'm like, covered.
So this is a systematic review done in 23. Again, they tried to use 24 hours, which seems the thing. This had 5 studies, some overlapping studies. Interesting, they showed pretty similar results at 6 months, but at a year, a pretty big difference in recovery in the ones that had been decompressed early. But the other secondary issues, such as DVT and hospital-related complications, were much less in the early surgery group. Mortality, ICU stay pretty similar. If they're getting MAP pushes, they're all going to be in the ICU for a few days, and it's really the MAP pushes that determine it, not so much their issues. So what else affects timing? OR availability. We talked about that earlier. Surgeon availability, OR and X-ray staff in the off hours. That didn't used to be a problem for us, but if I come in the middle of the night in our off hours to do a case, I often have people that I don't even recognize coming into my room, and the X-ray tech can't get an X-ray. Patient comorbidities, patient desires. So if it is truly emergency, the timing and timing clearly affects outcome, then these issues are all trumped by the injury. You have to go in the middle of the night. Okay, so there are times we do that. We tend to do that for, like, say, jump facets, okay, but probably not for this. So how do we decide? New instability such a fracture or ongoing cord compression, like from an acute disc, a change in the cord compression that's still ongoing after a fracture or disc herniation warrants a more aggressive approach to minimize secondary injury. And that makes sense, okay? If you sit there long enough, your foot's going to fall asleep. That means you had a nerve problem, and you have to get the pressure off the nerve to get better. The longer there's pressure, the more likely you get nerve problems. The quicker you get the pressure off, it gets better. It just makes sense. If we woke up in the middle of the night and our hand's asleep, well, get the pressure off your hand and it gets better. It goes away if it's early, okay? Makes sense. The Staska study was really a traumatic study, but included some central cords. And really it showed one, early surgery was safe, and this is less than 24 hours, and the ability to improve 2 ASIA grades was statistically significant. It's pretty soft data, but your ability to make a more dramatic recovery tended to be better if we did it early. So unfortunately, the surgical treatment can vary tremendously. It could be a 1-level ACDF, could be a laminoplasty, could be a multi-level fusion, and how severe the surgery is and the patient's comorbidities might influence your recommendation for early surgery. example, this is a 75-year-old male, mechanical fall from standing. He's Asia B. Always got some sensation. You can see how severe his multi-level thing is. There's no preceding symptoms, no new bony or ligamentous injury. This patient, I'm probably taking pretty early. He's pretty severe, the compression's severe. He's probably going within 24 hours and getting decompressed, and we did a laminectomy infusion. Unfortunately, he made no recovery from that. He ends up he's gotten a trach. I don't think we helped him, but that goes early. This is a different patient. This is a 35-year-old with congenital stenosis who had a several months history of some mild gait instability, hand clumsiness, and had a fall with acute worsening of the problem. So this is sort of acute progression of traumatic myelopathy. He's now can't get his buttons, no real neck pain. He can walk, but it's very spastic. That's probably somewhat pre-existing, and he already has intrinsic atrophy, and you can see his congenital stenosis. You can see the change in his cord, and this is a patient who we ended up doing the laminoplasty on. That's 4-year follow-up. He came in at this point. The reason I have it is because he had a radiculopathy with just some pain in one arm, and it allowed me to get an MRI. You can see at 4 years the amount of decompression you get. And you can see how you preserve motion, too, with his flexion extension of 4 years compared to pre-op. I have 25-year follow-up on this guy. So I actually ended up doing the laminectomy infusion, and I thought, well, did my laminoplasty close down? He started getting myelopathic worse. What happened was he started getting more degenerative disc changes because his neck moved and slowly compromised his canal again, and I ended up doing a laminectomy infusion. So new compression from an event or instability puts it into the trauma category. Chronic canal compromise, there's no harm in doing it early. Aggressive early in the more severe neurological injury or compromise. So I think it's clear in the Asia Bs and Cs, we probably ought to be pretty aggressive. It's maybe a little less clear in the Ds. If it's mild, then there's no rush, but logistically it is much easier to do while they're in the hospital. And the data currently supporting less than 24 hours is soft. We need new studies and more study, but there is data to support it. Thank you.
Thanks, John. Now to contradict everything he's ever written, Jim Harrop's gonna take the counterpoint.
Actually, if this is a murder trial, I might actually say, I'm actually gonna not even get up on the podium to talk because, John, everything you did supported me. Yeah. Now we have to. I don't know if I can get my slides up, or are they up here? But before I go into that, I just want to make sure, John, I don't know if you understood what our debate was supposed to be about. So I'm going to go through it for the rest of the audience because you didn't even go near there. You showed people. You gave a couple examples. One was an Asia B, which is not a central cord because your arms have to be weaker than your legs. And if you're paralyzed in your legs, that your arms aren't weaker than your legs, you're equal to your legs. So Asia Bs are not central cord injuries. Asia Cs are not necessarily unless they have some motor. Because remember, you could be an Asia C if you have sphincter control, which I'm not sure you do. And I'm pretty sure you're not going to after this. So this is what we're talking about, people, okay? When I say central cord injury, everyone in this room thinks about grandpa fell and has no fracture, and they have an injury, and they have a spinal cord injury. Now, your presentation was great. It did a great summary. You kind of got lost in the weeds and talked about major spinal cord injuries, but we'll get into that. A central cord injury is a minor spinal cord injury. And I agree, John, you agree with that. Somehow in your litany of inappropriate slides, I think you did kind of say that. But it's this. It's a patient that comes into your office, and I really like the fact that you showed us you can't do a laminoplasty on your elective patient, by the way. Patient came in and you did an elective laminoplasty. That really supports early surgery. And then what did we find out? It didn't work. But anyways, here's your patient. And what I just want to pull out really quickly is this. We're not talking about the patient who's getting worse, okay? That can happen. That patient goes to the operating room. And we're also not talking about the patient that gets the injury who's dramatically getting better, because I think we could both argue that. We're talking patient comes in, gets a central cord injury, and I'm going to argue with everyone else, and I think we agree, stupid name. It's the only spinal cord injury you get based on clinical symptoms. Nowhere else do we use it. except for central cord injuries. And somehow we try to pull them out as a different population. What we're talking about is this. Your Asia D patient, classically, they have a motor score greater than 90. And the question is, well, should you do nothing? No. There's a paper by a guy named Felling out there. He followed these people. They go to rehab, and what do? They get myelopathic, and they get worse. So you need to operate on them. What I'm arguing with John is, well, the guy gets drunk on Friday night, falls down the stairs, gets found Saturday morning, gets brought to your hospital. John, 24 hours. It's 9 o'clock at night on Saturday. You coming in to do them? Well, you just told me you're not going to do it because in your talk you said you don't have the right OR team. And that's exactly what I'm saying. I'm saying take a step back, let the guy get equilibrated. You're not going to make a difference if you operate on 23 hours or 36 hours in this population. And we'll go by. And one of the things I hope to talk to you guys really quickly is something called the ceiling effect. And that's why you're going to see this doesn't happen. So I'm going to go through this. I'm just going to really talk about it's a huge problem because it's all older people. We know that. This is a paper we just wrote. It just came out showing that the age of the average spinal cord every 2 years is going up by a year. So over the last 10 years, we've gone up 5 years. It's getting higher and higher. And why is that? If you look on the left, 80-year-old patients don't die. It's the most amazing thing out there. Again, we went through all these slides. It's a hyperextensive mechanism. Again, a clinical diagnosis. Somehow as spine surgeons, we are idiots, and we put every spinal cord injury together. Now, this guy this is why you don't fight with your brother in Philadelphia. They got in a fight. Knife. His brother stabbed him when he went to sleep. I was going to say, John, I felt like you brought a knife to a gunfight, but that's all right. This guy fell asleep. His brother stabbed him in the neck. He's a complete spinal cord injury. But somehow we put him in the same classification as a central cord injury. And so we're going to talk about central cord injuries. Great done, Schneider, you guys perfectly did it. It's not a central cord injury. So not only are we dumb with how we treat it, we're dumb in how we talk about it. This is a great paper. This is Schneider's original paper. And what was Schneider's conclusion? You shouldn't operate on this disease. That was the conclusion of his paper. But if you look at a central cord injury, this is Schneider what he said. He said you get the squeeze in the middle of the spinal cord. What's the problem with that theory, John? It's not the problem. This is a paper by a guy named Bungie. Bungie's started the Miami Center. But what he did is he took pathology of spinal cord injured patients. This is a central cord injured patient that fell. And what did they show? These are your neurons that died. The human knowledge of our corticospinal tract is very inaccurate. If you take a monkey and you cut their corticospinal tracts, can they walk? I'm asking you because you're the closest to a lower end primate I know. And the answer is they can walk fine. So the corticospinal tract's probably not as important as we think we do based on our Netter diagrams. This is a great paper. I recommend everyone read it. It talks about the tracts in our spinal cord, where they are and what they do. And it goes through the whole thing, and it tells us that, guess what? We're probably not where we need to be. So surgical timing, you can take all the animal data and throw it in the trash can because they don't operate on old mice. They throw them away. So none of this pertains to the elderly population. They don't have hyperextensive injury. And this is the big problem with the central cord injuries. And this is a big problem with the paper I wrote that John quoted. How is that? I know John never reads the methodology in the papers. How is central cord injury defined? John, you read the paper, you used it against me.
Yeah.
And all they did was they said, okay, the patient has a 5-point difference in their lower and their upper extremity score. And then they scanned the database. The problem is when you do that, you get your Asia C patient who's got 1 point. Is that the same guy as we're talking about grandpa who fell? It is not. We're talking about this guy over here. And what's the problem? Your recovery rate when you're 98, you don't have a huge recovery rate. So now you're talking about dragging grandpa to the operating room with the OB-GYN nurse at 2 o'clock in the morning to get a 2-point rate when his mortality rate's going to go up. And we'll talk about that thing. And John, I'll just quickly go through some of these things. Early surgery is not as benign as we used to think it is. 15% Marshall's paper. They took the Staskis study. They took Naskis, and Michael's not here, but I'm going to trash him later in the day when we look at the Staskis study. This is the only surgical, Michael Fellings has got 2 great things he's talked about, steroids and timing of surgery. He never brings up timing of surgery on the early use of steroids when probably the effect wasn't the steroids, but it was probably the early surgery. And we'll get into that later in the afternoon. But don't fear, John, I'm going to trash him too. Next, Jim Guest. Jim Guest is one of the brightest guys I know. Unbelievable study, tried to do this. This is the worst paper in the world when you're talking about methodologies. There's a huge selection party. He's got 24 patients. He takes the 6 sick people and he delays the surgery on them. And then he takes the 6 healthy people and says, yeah, I'm going to operate on them early. And what'd they find out? Hey, really wasn't a big difference. Yes, John, you are right. They do get out of the hospital earlier. But I'm going to tell you, is it earlier 1 day versus 2 days? To me, I'm totally fine keeping them an extra day and being a little safer. This was quoted before. This is the papers out there. Green is good. Yellow is no conclusion. Red's bad. This is all the literature on central cord injuries and timing for it. Not good. Guidelines, 2002. John, you quoted some of this stuff. Nothing. This is the big paper out there written by the Jefferson Group on central cord injuries. And if you go through it, and here's the classic point, John. This is the chart you never read when you're looking at the papers, John. The mean injuries, 1 to 50. That's what they started about. That's not the central cord injury we're talking about who has a motor score of 90. Sorry, John, you getting a little dizzy yet? And what did they conclude at the end of their paper, which you forgot to put out there? They said, hey, Central Asia C's, you should operate on them early because they do well. Why? Because they're not central cord injuries. But Asia D's, those guys you can wait a little while longer. They don't have to do it. Staskus, we talked about. John, great. And you totally hit the nail on the head. Although you can't do an Asia exam, you don't know what a central cord is. We'll leave that alone. It's 2 points. You got to get 2 points of conversion better. So what did you just say? 100% right. We're talking about D's. You can't get to an F. And I got to argue with you. You're going to see in the literature, I myself don't think I've ever seen an Asia E. An Asia E is a patient who had a spinal cord injury that goes back and becomes normal. Most of these patients, and if you've been around a lot of them, even the central cord injured patients, do not have normal hand function. And if you ask them to do their hands or you dynametrics, they are not normal. So I would argue with you, anyone who has a large collection of Asia E's, such as the Staskus paper, care for it. So in the whole Staskus study, John, we're talking about 2 patients in the early group versus 5 patients in the late group for central cord injuries. So I'm not really sure that applies there. And again, we talked about the thing, and I'm not going to trash the Staskus study too much, but there's a huge selection bias because they had tons of Asia A's in the early group, which are the ones you want because they improve letter. And in the late group, they had tons of Asia C's and D's, 20% difference, which skews your results. So when to intervene, again, the literature pretty clearly says if you have an incomplete injury, you're going to do well. If you have a complete injury, those are the people you urgently have to operate on. So my plea to everyone here is Asia A's are the ones you want to get to the operating room within 24 hours. That's the one I wake up the OR nurse in the middle of the night and I get them into the operating room. I'm just going to go through. John actually went through all this and actually supported my whole argument, so I'm kind of going to fly through them. Again, what's the big thing with all these papers? There's no data on it. There's no literature. And again, here's my paper. Again, John, thank you very much for doing it. And again, what did it say? And you kind of missed the big point because I pulled it out for you, is that Asia D's no different in any functional or motor groups. The Asia C's, which again, I'm going to argue probably aren't central cord injuries, those are the ones that do better. And lastly, when you take grandpa to the operating room in the middle of the night, what happens? Let's go to our general surgery colleagues who have multiple experience on this. And I'm going to fly through these next 4 papers pretty quickly, but every single one of them says horrible. The mortality rate for taking people in the middle or right, 28% versus 18%. Here's another patient where the patients do extremely poorly. If you look at the graph, major complications, failures, elderly patients taken in the middle of the night do much worse. Again, another study, mortality rate goes up much more. If you relax, calm things down, and do it electively, mortality rates drastically decrease. So, last slide, John, and I'll point it out to you. This is American College of Surgeries, where they looked at the central cord injured patients and the days to intervention versus their mortality. If you waited after 24 hours to do your surgery, your patients have a lot less chance of dying. And I know that's not good for you because then you have to follow them in clinic, but it's better for the patient. So with that, thank you.
Jens,
Dr. Harrop will have to run off to the surgery lab to show us how to fix the cranium.
Who wants
repartee.
theirs done early? Well.
How do you define early? Microphone. For online.
Would you get the patient from the trauma bay to the OR? Or would you?
I'm not coming in the middle of the night to do a central cord. So because I agree with Jim. I mean, it is a nightmare. But if they came in Saturday, I may come in and do them Sunday morning because I'm probably the one on call. So I'm probably coming in Sunday morning to do them. So if they come in during the night, I'm going to try to get them done the next day. That's basically it. So it does put them in within 24 hours for me. If they're severe, if they're really mild, in all honesty, I just try to get them on my next OR day to get them done while they're in the hospital because they're recovering. The other thing I think the problem with all these spinal cord injuries, if you look at their neuro exam when they first come in, or do you look at their neuro exam right before surgery? Because if you wait 3 days and they recover, you're going to see less recovery with the late ones. Whereas the early ones, if you do them early, some of that recovery was the natural recovery that would have occurred whether you decompressed them.
Correct.
This was always one of the arguments about the Staska study is where exactly was that neuro exam done from the time they came in or right before surgery. And so I sort of base it on, it also is how big the surgery is for me.
Yeah.
Like if I look and I say, this patient's a kyphotic deformity, it's going to need a front back. I'm going to try to do it with my really good team. If they need a simple ACDF or something smaller, then I'm not as reluctant to say, come in Sunday morning and do it with a team that may be not as used to what we do.
yeah, so
Microphone.
all these people are on Eliquis. So you got the 78-year-old who comes in with an ASIA C. Are you going to reverse his Eliquis just to get him done within 24 hours? Or are you just going to let things wear off and sort of more in a semi-delayed fashion?
Yeah, so you need 3 to 5 days to let it wear off. So if they have a spinal cord injury, one, I'm a little worried they're going to bleed into the cord area because, I think some of these do have a occult injury to the ligaments. So I'm reversing their Eliquis. Those are the few I reverse. If they're intact, like if I have a spine fracture intact, I don't reverse them. I'll wait till it wears off. But if I need to do surgery on them, I'm gonna reverse them. But that's a small group.
Microphone.
Handful of these patients will present with this real severe allodynia in the hands, and many others are absolutely, it just doesn't work. There's no pain. Do you have any, or does anybody have any idea what's going on?
I don't know.
And what to do.
That allodynia can be bad. Like some of them won't let you touch their hands.
Oh God, yeah.
Yeah, and it's bad. What I find is that usually recovers or improves pretty dramatically over a week or two, like even if you leave it alone. So that doesn't change me except, it raises awareness. They had a central cord. I don't know why some of them get that and some don't. I don't know if
Does it
anybody
make
else
them
has.
more likely to go to the OR?
No, if that's all they have, I'll go slower. That's that's a much smaller injury.
You don't have people full strength who have allodynia alone, do you?
I think we do sometimes.
Really?
Yeah, and it'll go away quickly though
I've never seen that.
in that group.
I'm going to put a young colleague who's going to start. She's a neurosurgeon who's going to Nebraska. So you're an impartial audience. You'll have to define care in a big university hospital in Nebraska. What is more convincing to you? What are you going to do when you have an acute central cord syndrome, whatever it might be, in your office?
I mean, I do think we really do have to look at the patient. There are a lot of variables in play here. I think I am leaning more towards an earlier within 24 hours intervention, but again, with the consideration that you have to have the right OR team in place.
Yeah, I don't think the data is strong enough to be dogmatic about going in 24 hours. I think that can be your sort of default, but you have to be willing to back away, like you said, depending how sick the patient is, whether they're on Eliquis, whether you have a good OR staff, how big the surgery is, how large the magnitude of the surgery is.
Actually, I have another question for the faculty with regards to central cord. I have recently seen a colleague who lays their central cords flat to improve perfusion, but then you have concern for aspiration risk. Any thoughts on that?
I probably wouldn't do that. I put him in a collar and let him mobilize. There's a lot of things bad about laying flat, not only aspiration, but, DVT, pulmonary issues. They're not unstable from a mechanical standpoint. I do put them in a collar to rest the cord, but I let them mobilize.
Going on, Dr. Trent Treadway is next to me, an experienced neurosurgeon. And what convinced you most now? Has any opinion of yours changed in what you've heard?
It depends on if I want to operate. No, I'm just kidding. The central cord syndrome is tricky, and I think Jim did a great job. These are the really good functioning patients. If you're going downhill and you do surgery, they're probably going to do pretty poor after that. One of the things that's important too is how many people are monitoring during these cases, neurophysiological monitoring, motor evoked potentials, SSEPs. Do you see changes? Do you see improvement before and after? And I'm leading you guys down a path here. So most people are going to do it, right? Is it really standard of care? I think Vince Trinellis presented a nice paper many years ago. I think it was in Miami, and he pointed out that a lot of this monitoring isn't really helpful unless you're doing intradural, intramedullary. Because once you've had a change, it's too late, right? Now, I have 2 patients that I have central cord that developed it after surgery, which is kind of odd, right? And so I didn't understand what happened. They were pretty myelopathic. I did their surgeries. They got better. The next day, they're getting ready to go home, and all of a sudden, they got the numb, clumsy hands. Once again, classic central cord syndrome. Put him on some steroids. He improved. I did not take him back up because I've already done the decompression. He actually had to come over here for some rehabilitation. He actually did fairly well, but he's still pretty messed up. Coming in, he was pretty myelopathic. Didn't really dawn on me what was actually happening. Another patient about 2 months later, same thing happened. Guy couldn't use his arms, myelopathic, did his surgeries. The motor evoked potentials during the surgery were improved at the end, and I'm high-fiving everybody. The guy does well. I discharge him the next day, calls in. He's coming in a wheelchair. He can't hardly move. Classic central cord syndrome. Now, that second patient, when we were doing the surgery, he basically had the last motor evoked potential that was sent, right? And we go over and look, and he kind of bit his tongue. A lot more blood loss from the tongue biting than the actual surgery, right? And it dawned on me, what are we doing with these motor evoked potentials? Our really, really sick patients that are really myelopathic have bad spinal cords. But our monitoring folks are off-site, and they have the techs that are kind of pushing it, right? So we're actually really raising the bar, right? How much are we really electrocuting these patients? So does anybody know what are they milliamps or are they amps that they're using when they're actually doing motor evoked potentials? The answer is volts, right? And so they're running at 250 to 300 volts sometimes to get these patients to get some sort of response. They run 2 leads, that's times 2. Some of them are running 4 leads. So some of our monitoring people are they came up to me, they said, hey, just want to let you know. And when you monitor, you see them jump, right? This is a classic example of cord injury from the monitoring. So we have to be very careful. And this is one of the things that the folks here, especially the fellows and the residents, you're in there and you're like, hey, we need to get a response. You need to get a response. Do not electrocute people. 240 volts, that'll shock you, right? That's dryer, right? And so then now you're putting in 500. If you do 2 leads and you're doing 250, you're getting 500 volts. And my technicians who we work with came up and told me this. I'm like, this is a little bit of an issue. So we have to be very, very careful. So the 2 central cords I've seen, post-operatively, the motor evokes were better. The central cord syndrome, I did not operate on it. In retrospect, if I would have operated on them, I think they'd have probably got worse, to be honest with you. So
It's interesting that you bring it up. I'll tell you a funny story. I had a patient once who we were doing surgery. I can't remember exactly the nature of it, but in the course of it, we lost some signals and we were doing a wake-up test, which I'll do to back it up. And so I started the wake-up test. The wake-up test was going on for a little while. Probably right when they were about to wake up and start being able to move to do the wake-up test, our tech, he decided he would give it one more check with the motor. You want to see a guy come off the table, you send a bunch of electricity through his cord. This guy took 2 of us to hold him down, and he went crazy because they literally jolted electricity through his spinal cord right when he was about to wake up.
Wait, I can't hear you. Hey, how are we doing in the lab?